ribuan gitu ya, masih ada kuota 4 orang. Nanti kita juga akan ada door prize utama, buku gitu ya, buku tentang wound management dan disaster wound management dari Prof. Hari Krishna Malaysia gitu ya. Dari Malaysia seharga 1 juta rupiah buku ini ya nanti ya. Jadi buku ini, keilmuan ini memang mahal, dan dari Malaysia beliau akan memberikan buku ini secara gratis kepada salah satu peserta seminar kali ini gitu ya. Jadi nanti benar-benar harus disimak, benar-benar harus diikuti detail acara kali ini. Nanti untuk mendapatkan buku ini akan kita kasih tahu kisi-kisinya di akhir gitu ya. Tapi untuk voucher OVO-nya kita kasih tahu kisi-kisinya cukup menyimpulkan materi hari ini gitu ya. Jadi kalau voucher OVO kita syaratnya cukup menyimpulkan materi hari ini gitu ya. Kalau bukunya nanti senilai 1 juta rupiah itu yang sudah diimpor dari Malaysia akan kita datangkan ke rumah panjenengan semuanya gratis, syaratnya nanti akan kita bagikan di akhir. Nah, seperti itu. Kita juga ada door prize juga yang lebih gede, 1 unit Toyota Avanza. Dalam bentuk brosur. Ya, beli sendiri ya. Nah ya, door prize kita ada 2 tadi ya. Jadi selain saldo OVO, kita juga ada door prize buku tentang wound management dan disaster wound Malaysia. Nah, ini dari Prof. Hari Krishna. Nanti bisa disimak sampai akhir gimana cara mendapatkan buku ini, seperti itu. Oke, kita ucapkan selamat datang buat yang baru datang sambil menunggu. Masih ada 99 orang yang bergabung. Nanti akan kita bagikan juga link untuk absensi di hari yang kedua, teman-teman ya. Sambil menunggu yang lain dulu, biar tidak mengulangi lagi kita nge-share daftar hadirnya, gitu ya. Nanti kalau daftar hadir kemarin, untuk hari pertama mungkin ada yang belum mengisi, gitu ya. Nanti bisa dicanangkan ke panitia link absensinya. Karena dari daftar hadir nanti yang kita pakai untuk mencetak sertifikatnya teman-teman gitu ya. Nanti ada namanya dan lain sebagainya. Nah. Baik teman-teman semuanya, selamat berhari Minggu. Ini yang masih bekerja gitu ya. Selamat bekerja, tetap semangat walaupun harinya hari Minggu gitu ya. Mungkin kalau yang di rumah sakit karena shift pagi gitu ya. Wah. Atau yang pulang dari dinas malam juga tetap semangat. Nanti akan kita mulai pada pukul 8 sambil menunggu yang lain dulu bisa masuk. Baik, good morning everybody. Ini kalau saya lihat di partisipan, sepertinya pembicara pertama kita ada Prof. Kevin sudah masuk di link Zoom. Good morning, Prof. Kevin, apakah sudah bisa terhubung? Can you connect link Zoom? Prof. Kevin.
Good morning. Can you hear me okay?
Yeah, I still listen you. Baik teman-teman semuanya, acara hari ini akan dipandu oleh moderator. Sebelumnya akan saya buka dulu. Assalamualaikum warahmatullahi wabarakatuh. Baik. Yang kami hormati Ketua dan Direktur dari Go Eye Care Foundation, Bapak Asmat Burhan, MKEP ITN, dan tim yang saya hormati segenap jajaran dari PPNI, Kabupaten, Kota di Jawa Timur terutama, dan di DPP PPNI Pusat. Baik, langsung saja karena pembicara sudah terkonek di link Zoom kita. Baik, untuk moderator di sesi yang pertama ini spesial gitu ya, yang akan memandu adalah direktur kita dari Go Eye Care. Beliau bernama lengkap Bapak Asmat Burhan, gitu ya. Nah, lahir di Bangkalan. Sebelumnya mungkin saya cek dulu apakah Pak Burhan sudah terkonek di link Zoom ini.
Yes.
Alhamdulillah. Baik.
How are you? Hi, Prof. Kevin. Thank you.
Good morning, Asmat.
Yes, I am fine.
Baik.
Thank
Baik,
you for opportunity join in webinar.
Thank you.
Okay.
Bapak Ibu semuanya, saya perkenalkan langsung moderator kita hari ini akan dipandu oleh Bapak Asmat Burhan. Beliau kelahiran di Madura gitu ya, dan sekarang beralamat di Jalan Raden Patah nomor 100 Kembaran Banyumas ya. Sudah banyak sekali publikasi yang disampaikan beliau, dipublikasikan oleh beliau. Ini mungkin saya bacakan satu-satu mulai tahun 2020 ini ya, tentang A Pocket Book for the Common People, ini tentang diabetes mellitus, hypertension. 2021 Effect on Compression Bandage on Healing on Diabetic Foot Ulcer. 2022 The Combination of Begin and Sedomemer Iodine in Healing Chronic Venous. 2022 ini ada 3 buku yang sudah diterbitkan oleh beliau. Nanti mungkin apa saja teman-teman bisa tanya langsung sama beliau. Baik, ini pastinya juga beliau sangat luar biasa ya. CV-nya sangat banyak sekali. Langsung saja saya tidak akan membacakan satu-satu. Nanti mungkin Mas Burhan kemarin sudah diperkenalkan pembicara hebat kita, Pak Direkturnya di Go Eye Care Foundation. Baik teman-teman semuanya, kalau gitu waktu dan tempat saya persilahkan dipandu oleh moderator hebat kita kepada Bapak Asmat Burhan. Dipersilahkan.
Okay, thank you for Master Ceremony, Mr. Rahmat Husik, Mr. Kevin, Prof. Kevin. How are you today, Prof?
I'm good. Thank you very much. A bit cold in Canada. We have -20 this morning, so I'm very envy that you're in a very nice weather, and I'm sad that I won't be able to join you in person. But thank you so much for having me.
Thank you very much. It's been a while since we met. It's really nice to you again, Prof. Kevin. This year, we in Congress Abu Dhabi 2020. And thank you for taking the time to join and be keynote speaker at this webinar with your busy schedule. Okay, are you ready to present, Prof. Kevin?
Sure, I'll go ahead and share my screen then.
Okay, I will read out Prof. Kevin curriculum vitae.
Okay, thank you so much again for inviting me to participate in your conference. And it's such an honor to be able to have this opportunity to share with you my many passions in wound care. And one of the projects that I've been doing and quite involved in the past 10 years is around skin tear management. So Asmat asked me to talk about skin tear best practices. And I thought that I'll just present some of the challenges and some of the different elements, and hopefully they're refreshers for you that you already have been doing those type of practice in your clinical practice, and perhaps a reminder that there are best practice around skin tear management. I want to start with looking at the skincare problems. I did a small study to look at, in our province, our jurisdiction, the number of skin-related problems in Ontario, in our province. We look at different sectors from acute care, home care, long-term care to complex care. And we're surprised that we have looked at about 250,000 individuals in a database, and pressure injury continued to be a problem. As you can see, complex care, 30% of those individuals have some evidence of pressure injury problem. And of course, more sort of pertinent to what we're talking about today is skin tear problem. We didn't think that skin tear was a big concern in our province until we look at the numbers in our database. And I'm actually quite surprised to see that 26% of people in the long-term care facilities had some type of skin tears or laceration problem. So it'd be nice for you to reflect on your practice in your institution in Indonesia, the type of skin tears and the number of skin tears that you see in your practice. And perhaps that's one of the reasons why we need to pay more attention about how we can prevent and manage skin tears. So skin tears, they don't become a chronic wound problem, and there are ways that we can facilitate faster healing. And we know that as we get older, our skin had undergone a number of changes that make our skin more likely to develop skin tear problem. As you can see in this diagram, the skin is divided into many layers. With aging, that we know the epidermis gradually become thinner. And that's why when we look at aging skin, they're so thin, so transparent because of the loss of subcutaneous tissue, and also, also because decrease in the number of cells, making it much more thinner. And the other interesting thing is about what we call the epidermis and dermal junction. As you can see in this diagram on the bottom here, you see the two layers of skin that anchored against each other by all this undulation, like a key and the lock kind of mechanism. So when those undulations, when those key and lock mechanism becomes more flat, then even with minor trauma, we can separate the skin so easily. And that's why with aging skin, we see that the skin is so vulnerable to developing skin tear problem, even with very minor mechanical forces. We have seen patients being mismanaged. They're being repositioned. They're being dragged from the bed to the stretcher, from the bed to the chair. And that's enough force to induce trauma resulting in skin tear problem. So you can see that this is a nicer picture to show you the flattening of this epidermal junction. In normal cases, you see all this little curve, sort of depicting the two layers of skin, how they connect with each other. With aging, this kind of lock and key mechanism has disappeared, and that's why it can separate so easily. What about the dermal layer? It's also had undergone a number of changes. There's lots of collagen, elastin, so the skin is not so stretchy anymore. And when it's not so stretchy, it cannot sustain very high mechanical force. And also we see that the skin can become more dry because the sebaceous and sweat glands, they're not as active to produce natural lubricants on the skin. Especially in my country in the wintertime, it's so dry. I get cuts and I get skin tears all the time myself, just because of the skin being so dry. And we'll come back to this point about the importance of managing dry skin as a way to prevent skin tears. And there's a very nice study done by Dr. Carvell in Australia that I'm going to share with you later on. And of course, I alluded to this change earlier, that in the subcutaneous layer, there's less fatty tissue, less cushioning around the bony prominence, and with the loss of capillaries, and once it's broken, when it's damaged, it's taking a longer time to facilitate the healing process. So what are skin tears? Well, I'm sure that we can all recognize what skin tears may look like, and these are some of the pictures depicting what the skin tears are like. And if you're not aware of the best practice recommendation, we actually, the ISTEP group, the International Skin Tear Advisory Panel, including a variety of experts from across the globe, developing best practice recommendations. One of the recommendations is to use a standardized language to describe skin tears. In fact, we have different ways of describing it. As you can see in this picture, you can see the skin flap here, and there's a skin flap here. And the skin flap, if it is still partially covering the wound, and this is what we call a type 2 skin tear. And this is also another example of a type 2 skin tear, because you can see a partial skin flap still covering part of the wound bed. So it's not entirely removed from trauma. So how do we address skin tear and doing assessment? One of the major things that we want to raise some awareness is similar to what we do for pressure injury, doing a comprehensive assessment to determine individuals who are at risk for developing skin tears, so we can prevent skin tears from happening. So we understand that there are a few different risk categories. We just talk about aging skin, how aging skin, with all those normal physiological changes, make those skin more vulnerable to skin tears breaking down, especially when it's dry, especially if there are medications that make the skin so much thinner. Medications such as steroid is a huge factor that can cause skin atrophy with the thinning of the skin. Obviously, again, with the trauma, with a little bit of manipulation, we can break down the skin so easily. What about mobility here? As you can see, people at risk for falls, impaired mobility, if they have problem moving from one place to the other, they're at high risk for developing skin tears, just because skin tears often occur during those episodes of transferring, during the episodes of having a fall. We also have to look into the general health, the comorbidities, the type of medications they're on. Do they have any sensory deficit that make them more prone to falling? And also malnutrition, because if you're malnutrition, you don't really have a lot of fatty tissue. And again, those adipose tissue, the subcutaneous layer, is so vital to provide the cushioning for the dermis and the epidermis. And of course, the more medications people are on, the more likely they develop drug-drug interaction, and we have to keep that in mind. So when individuals have one or more risk factors, such as visual impairment, impaired mobility, they're dependent on activities of daily living, or they have previous skin tears, they're more likely to develop further skin tears. So really, those are the red flags that we need to highlight to alert your colleagues to develop a plan of care, so we can institute interventions, early interventions, to prevent skin tears from happening. And we did a small study actually to evaluate the at-risk skin, if you may, and the terminology that's been sort of introduced in the literature is called skin frailty, frail skin. And if you think about skin that is not healthy, skin that can break down very easily, some of the clinical signs and indicators for frail skin include here senile purpura. And this is a very nice picture to show you that there's a lot of purpuric purple color lesions on the skin. And we don't really exactly know the mechanism. Perhaps that is due to those fragile capillaries when they break down that result in some subcutaneous minor bleed into the skin. And that's why when we evaluate the skin, you can see all those purpuric lesions as evidence of the fragile capillaries breaking down. There's also another indicator, it's called the stellate pseudoscars. And what you can see here, some of the whitish discoloration on this arm, they are pseudoscars. And what it means is they look like scarring, but not exactly due to the normal scarring process. What I would think from my clinical experience is that because of the minor trauma, there's inflammation, and there's perhaps some of the minor cut, minor opening that has healed. What's left behind is some of the newer skin, the scarred skin. And we know that when the skin is replaced by scarred tissue, those type of skin has a lower tensile strength. They don't really have the same kind of elasticity. And that's would put the individual at high risk for developing further skin tears. And in my research, I use the term frailty to refer to skin that has very irregular texture. There may be thinning of the skin, loss of tensile strength because of abnormal skin hydration. And you may be able to see that there's a change. And we did some microscopic study to evaluate skin. As you can see on this picture here, under the microscope, the skin can see the characteristic of the skin that is at risk is even more visible to us. What you can see is all those capillaries distribution on the slide here. And also you can see that the skin has this pearly white characteristics. So it's not very opaque, but very transparent. And the other thing is there's a lot of different color on the skin. So we identify that with the inclusion of different color, perhaps this is an indicator for skin. Hopefully I can come back to share with you some more of this type of research once we complete our data collection to validate how we can teach machines to recognize frail skin. That's part of what we're trying to develop, an app that you can scan people's skin and identify the risk factors for frailty. So we also know that we need to look at other internal risk factors and also extrinsic risk factors. And mechanical trauma, the risk for developing trauma, whether it's because of the visual impairment, cognitive impairment, are the risk for falls. So we need to recognize some of those risk factors. Individual healthcare providers, we as healthcare workers, we as nurses are also responsible for many skin tears. I think in Indonesia, people are more strict about what you wear to your practice. Unfortunately, in my clinical practice in Canada, a lot of times we still see people wear lots of jewelries. They may have long nails. They may have other watches and other things that they wear potentially that can traumatize people upon contact or during transfer, during care. And there's so many times we see that people accidentally scratch on people's skin and that results in skin tears, as you can imagine. So that's why I think the attitude that we have, how careful we are with manipulating, with transfer patients is so important to protect their skin. And of course, the physical environment, again, I've been into Southeast Asia a few times, and I know there's some environments, and they're not so different from ours. And we see clutters everywhere. We see wheelchairs parked outside the patient's room, or sometimes even in patient's room. We see patients' washroom full of all kinds of equipment, and there are risk elements for increasing the risk for falls. So we need to pay attention to what's in the environment to prevent falls and prevent some of those accidents from happening. And I think if you look at this little study, looking at a survey to evaluate the incidents and circumstances in which skin tears developed. In most cases, skin tears are linked to blunt trauma, and a lot of times it's related to falls. As I said, it could be even during care, as much as when they're just getting dressed, putting up the socks. That may be enough to induce shear and friction to the skin that cause trauma to the skin. And sometimes it could be dressing. When dressing, we're talking about wound dressing or treatment-related factors. As you can imagine, a lot of dressings have aggressive, strong adhesive. And if we're removing and peeling off the dressing in the wrong direction, or if we're doing it too quickly and too aggressively, we can induce another skin tear and extend the skin tear. And we'll come back to talk about another study that we have completed to look at the different dressing types that may facilitate skin tear healing by using a non-traumatic, atraumatic type dressing. And of course, a lot of skin tears may be related to episodes of patient transfer or equipment-related type injuries. So I think it's important to look at the combination of intrinsic factors, what the patients are like, and looking at the environment, and don't really think that environment has nothing to do with skin tears. I think it's play a very, very important role, and then we can actually prevent a lot of skin tears from happening. So there are recommendations from the ISTAP group, the International Skin Tear Advisory Panel. Once the skin tear has developed, first, we need to clean the area, control the bleeding, especially if it's due to trauma. We need to make sure we control the bleeding first by maybe applying pressure, applying some of the hemostatic type material. We know the calcium alginate will have some hemostatic property or some other type of material. We cleanse the wound gently. We don't rub, because by rubbing it, we cause more trauma. And the other important thing is to reapproximate the skin flap. And I'll show you a slide what I mean by reapproximating the skin tear. So basically what we do is to roll the skin flap back in its original position as much as we can. And then we assess the skin tear to determine the type of skin tear and also look at the surrounding skin. And then we can determine the goal of treatment. And the goal of treatment may involve selecting the appropriate dressing and also prevention and preventing further skin breakdown, further skin tears from happening. And then we can come back to look at the patient to evaluate whether your interventions were successful or not. So I think this is a nice little flow diagram just to illustrate the complexity of skin tear management and comprehensive care that is required from every one of us to be very diligent and be cognizant and pay attention to the many factors for skin tear healing and prevention. So first of all, I want to make sure that we understand not all superficial skin damage is related to trauma or skin tear. Remember, the definition of skin tear is induced by blunt force trauma, whether it's from bumping into the chair or falling or by accidentally trauma from aggressive adhesives. But looking at this wound, what do you think? This is not skin tear. Look like skin tears, but they're not really skin tear because it's not from trauma. And what it is a patient. It's interesting because one day I went up to the unit and they said, well, Kevin, you have to come and take a look at this patient. He got skin tears all over the body. And when I look at this patient, they're blisters, first of all. And when the blister popped and they were opened, and of course it looked like skin tears. And when you see blister all over the body, we recognize this is a systemic disease. In fact, this patient has a skin condition called pemphigoid disease, bullous pemphigoid. So that's why it's an autoimmune disease that your body produces antibodies to attack the junction between the dermis and the epidermis, resulting in inflammation and fluid production. And sometimes you can have pus build up, as you can see on this diagram here. So, and exactly what we see on this picture is not from trauma, but from an underlying disease. So if we don't address the underlying condition, and we just thought that by putting a dressing, by putting all the other intervention, we can prevent some of those skin tears from happening, then we're all wrong, because we need to think about systemic treatment to prevent some of those blisters from happening. In this case, the patient will require steroid therapy. And look at this patient here, there's a little bit of a blister. And so again, the nurses asked me to come and take a look at this wound and then say that, well, there may be a skin tear that is developing. Well, I took a look at this. Again, this is not related to a risk skin tear, but it is a stasis disease that people with venous disease, they tend to have edema develop in the lower extremity. And because the fluid built up in the lower extremity, and they had to find a way to escape, resulting in blistering. So, I hope that by providing with a couple of cases, really to showcase, to remind you the importance of looking at the etiology and also recognize and classify skin tears appropriately. So once the skin tear is developed, what we need to do is to reapproximate the wound edges. And I think this is a very nice series of diagrams to show you step by step how to manage skin flap in association with skin tears. So first of all, you can see that under A, there's a skin tear developed. And because of trauma, the skin flap may be moved away from the wound, it may bunch up, it may look like it's a piece of dead tissue, perhaps. So what we need to do as early as possible, while the skin flap is still viable, because the longer we wait, the more likely the skin flap is going to dry up. And the skin flap, when it's dried up, when there's no circulation, when there's no blood contact, then it's going to die off. So we want to keep the skin flap viable by rolling it back to its original position. As you can see, we sometimes might have to moisten the skin flap a little bit so it's a little bit more pliable, and use your forceps, or sometimes we might use Q-tip to slowly, gradually, gently roll this back to this original position. As you can see under picture D, now the skin flap is covering the entire injured area. And why is it important to cover the injured area? Not only because we want to promote the viability of the skin flap, but also think about, of all the dressings that we are trying to use, the ideal dressing is trying to emulate the normal physiology of skin, of the epidermis. So when you have the epidermis, why not using the epidermis as your natural dressing to cover the wound bed, right? So that's why it's so important to roll back the skin flap to create an ideal environment for wound healing. If you think that that technique was a little bit challenging, alternatively, you can also use Q-tips. And sometimes we use 2 at a time. We moisten the skin flap, making it more easy to move. And then we use the Q-tip and slowly roll back. It's not a sterile technique, but we usually recommend people to use sterile Q-tip just to prevent infection issue and cross-contamination. And sometimes I use this, I call this a chopstick technique, just like using a chopstick and roll things back. And then you can put a dressing to cover the entire area. And the assessment of skin flap is very important as the determinant for how you're going to classify the different types of skin tear. So the type 1 skin tear, it's moving by itself. The type 1 skin tears are the one that you can roll the flap back, and the entire wounded area now is being covered by the skin flap, so it looks like it's a linear skin tear. So this is type 1, with a viable skin flap able to cover the entire injured area. Versus a type 2 skin tear, you have partial tissue loss. So part of the skin flap is lost due to trauma, due to the excessive force that now is being detached from the skin altogether. It cannot be repositioned. So you're exposing part of the injured area, exposing the wound bed. And type 3 is the type of skin tear that the entire skin flap has been removed due to blunt force trauma, exposing the entire wound bed in this case. I think our next stage of research is to really determine the healing rate for the different types of skin tears. My gut feeling and my guess and hypothesis is the type 3 skin tear may take a longer time to heal than a type 1 skin tear. I think it may be common sense, but we don't really have a lot of good research to demonstrate that yet. So perhaps people who are interested in research, this is another interesting research area for you to pursue in skin tear. And remember that skin tears are acute wounds, and we're trying to minimize as much pain as possible, because just like any cut, like any acute wounds, there's an acute inflammation process going on. So there may be a lot of swelling, a lot of erythema developing in the area due to trauma. And once the skin is open, there's always a risk for infection. So keep in mind that we need to come back to do assessment and evaluation to determine if there is any increased drainage, smell, and also increased level of pain or localized swelling that will be indicative for infection problem. And for the interest of time, I don't really have a lot of time to talk about how to recognize wound infection, and hope that there will be other speakers helping you to understand the nuances and the subtle signs associated with wound infection. And our treatment approach, and have to think about moist wound healing. We don't want to leave the skin tear open. There are many research since the 1960s indicating and suggesting that by keeping the wound moist, not wet, not dry, the right amount of moisture is able to facilitate faster, better healing than leaving it open. The general management by leaving a skin tear open may take a longer time, may actually cause more trauma, and may actually slow down the healing process. So we have to be aware of local signs of infection. When there's edema, we need to think about using compression therapy to promote better wound healing by reducing the swelling. Because by reducing the local swelling, we can actually oxygenation to the skin. We also want to make sure that we take care of the surrounding skin, preventing pain, and also ensuring there's enough blood flow to support the healing process. If there's not enough blood flow, then we might have to refer to vascular surgeries. We might want to think about how to manage the wound differently. So in ideal dressing, there should be a very gentle adhesion. With the dressing, and a lot of the glue-like substance, they can actually create a more aggressive bond over time during the wear time. And that's why the longer time you wear dressing, the more likely the dressing is going to stick to the skin and stuck to the skin. And that's not an ideal type of adhesive. We want to make sure the adhesive is able to be peeled off and removed very easily without creating a strong, aggressive bond over time. A dressing should have good absorbency, especially during the inflammatory response. We expect more fluid. It should be soft and flexible, understanding that a lot of locations where skin tears may develop. Has a very interesting contour, right around the elbow, around the head, around the rib cage, whatever location. It has a very different architecture. So it's not a flat surface. We need to have a soft dressing that can conform to the contour. And we want to minimize the changing frequency. The more often we come back to change dressing, disturb the wound, the more likely we can damage and cause further issue with the wound healing process. And of course, we like to have dressing that's waterproof. They allow patients to perform day-to-day care. Just a reminder, when you're putting a dressing on the wound, foam dressing is very, very popular for us. And that's why I'm using a foam dressing as a good example. Making sure that you draw an arrow to indicate from where the dressing should be removed. You can imagine if the skin flap is the way it is, curved in this direction, and if we remove the dressing from the opposite angle, we can actually take the skin tear along with the dressing upon removal and causing further damage. And that's why, unless you're quite confident that you'll be the person coming back to change the dressing, then you don't need to worry about that. You still want to remember which angle that you should be starting with the removal process. And I think the ideal dressing is atraumatic, should be atraumatic, doesn't cause any trauma. And we did a study to evaluate soft silicone dressing with silicone coating on the interface versus something called the non-adherent dressing. Remember, those terms are not the same. Usually with non-adherent dressing, they would maintain non-adherent if the wound dressing and the wound interface and the wound bed is kept moist. A lot of times, the dressing can be dry up, and making the non-adherent dressing still sticking to the wound, versus atraumatic dressing are very different in terms of the property of the silicone. It doesn't need moisture to produce that interface that when you're removing the dressing, it doesn't cause any trauma, doesn't remove any skin, doesn't cause any skin stripping. So, and to show you the evidence, we did a randomized controlled design study. We follow patients for a few weeks, and the treatment group is the one that was the one who received the soft silicone dressing, versus control group, they received the non-adherent dressing. And you can see that actually in the treatment group, the soft silicone group, their surface area was much bigger. So actually put them in a more disadvantaged position. And after 1 week, we're able to see that in the treatment group, they heal faster. And 13 of those wounds closed versus only 4 in the control group achieved closure. So just to show you a few pictures here, this is a type 2 skin tear, because you can see a little bit of the wound bed exposed here. We applied the soft silicone dressing, and we left the dressing for about 5 to 7 days. We want to leave the skin tear healing undisturbed as much as possible, as long as possible. So when we come back to remove the dressing, evaluate the skin, you can see the wound is almost healed with the new epithelium. Of course, what I did not do in this case, that what I have just talked about, is to put an arrow to draw on the foam dressing to make sure that remove the dressing from top to bottom, not the opposite direction. Otherwise, we can take off the skin tear, the skin flap along with the dressing. But anyway, because I was the one doing the dressing, so I remember how to remove it. So in this randomized control design study, we're able to use the dressing to promote better wound healing. What about prevention? This is a very, very nice study done by Professor Carvell in Australia, and they did a big randomized control design studies with about 400 residents in long-term care. They look at follow individuals over time. What they have instituted as an intervention is to apply moisturizer 2 times a day, and a moisturizer that is pH neutral with no perfume, no fragrance, and they're able to reduce the skin tears by a significant amount over time. So there is a almost 50% reduction over time by using this regimen. So I think, so hopefully this is a really an important tips and pearl for you to bring back to your practice, that by regular moisturizing your patients, residents, we can reduce skin tears. If there's also identify the risk factors, we can put care plan in place. Once skin tear has occurred, perhaps a soft silicone type dressing is the best atraumatic material that we can use to promote better wound healing. All right, so I think my time's up in terms of trying to stick to my 30-minute presentation.
Thank you, Prof, for the presentation. This is the thanks for the sharing the knowledge about your skin tears. And this is the very interesting, the skin tears treatment. And because skin tears is new science in nursing from Indonesia. This is the very first from Indonesia in nursing. Okay. Maybe any question from the participant? Okay. Ada yang mau bertanya ke Prof. Kevin terkait ini? Nanti saya bantu translate bahasa Inggris. Prof. Kevin, sorry, in Indonesia, very low for speak English. This is, I'm the translator from the participant for Prof. Kevin. Okay. Ada yang mau bertanya?
Good morning.
Okay, good morning.
Good morning. I'm sorry. I think.
Okay. Siapa namanya? Silahkan dijelaskan dulu ya. Untuk operator bisa di spotlight dulu. Spotlight.
Okay, can you hear me, guys?
Yes.
All right, my name is Wayan. I'm from Bali. Actually, now I'm working as a school nurse. I have question in mind regarding wound care. What I have in mind is, what if we have like a superficial wound, such as a excoriation wound? Is it necessary to cover it up, or just leave it alone and let it dry? Just apply antibiotics, some kind of cream, or which method it's suitable for that kind of wound, sir? Thank you.
Thank you so much for your question. And I'm sure that in your practice at school, you come across a lot of those children falling and getting into some accident and result in excoriation or abrasion. I appreciate that question. So it's not straightforward. I don't want to make one sweeping statement, but in general, by keeping the wound covered, by keeping the area covered, we can facilitate the right amount of moisture on the wound bed to facilitate the epithelial cells to move towards the wound, to cover, to provide, to build new skin, so to speak. Now, you talk about, yes, we can use antimicrobial cream. In our country, we have something called the polysporin cream ointment. And a lot of those cream and ointment, because of the type of vehicle, a lot of times the antibiotic agent is impregnated in Vaseline. So what the Vaseline can do is basically creating a coat, like a film on the wound. And at the same time, it's basically like a dressing, covering the wound to promote, to optimize the moisture to facilitate healing process. So that's why I'm saying that, yes, in some situations that putting a dressing may not always be ideal because there's a lot of moisture. We think about people incontinent in my practice, and when there's a lot of soiling, so putting a dressing may not be always the best approach. So the alternative is we can put something, a occlusive cream, to put on the surface to make sure that we provide the environment that is ideal for healing process. Hopefully that kind of makes some sense to you.
Yes, sir. Thank you. Thank you so much for the explanation.
Okay, thank you for the question. Maybe any other question for Prof. Kevin?
Good morning.
Yes, morning. The on camera for the like in operator.
Hello, Mr. Kevin. My name is Erlangga from Jakarta. I have a question. I saw in your slide there is a adhesive dressing. Is it suitable for all sort of wounds, or just a certain of wounds? Because I have experience also in Netherlands. We were using mostly with the adhesive dressing, and one more question. Actually, which sort of fluid for cleaning the wounds? Because when I was working in the hospital, we use the NaCl, but in the home care in Netherlands, we were using the fluid water, flowing water in the bathroom. Yeah.
Excellent question. I appreciate that. Again, I'll answer the cleanser, the wound cleanser first. There was a Cochrane review to look at the different types of solutions for wound cleansing. and they found that normal tap water was just as good as cleaning a wound as normal saline. It does not increase the risk for infection. Now, of course, it depends on the situation, depends on the country, depends on the type of water being used. And even in our country, in some of the country area where they don't have the factory and plant to process the water. So sometimes if you get the water from the well, you could have lots of bacteria, pathogens, fungus in some of those water because they're not drinkable. So you would not be using those type of water to clean a wound with the risk of introducing foreign pathogens in the wound environment. So if the water is clean, then I think it's probably good enough for cleaning wounds in a home care environment. And of course, you still have to take into consideration the type of patients that you see, whether the patient is on immunosuppressive drugs, and if they have other risk factors for infection. And with people, for people with diabetes, I will be a little more careful in terms of how we clean the wound as well, because they're high risk of developing infection. I know that in Indonesia, just like anywhere else, that there is a growing number of people with diabetes, so we need to pay attention to that. Antiseptic solutions like NSL or Dettol and in other countries, I don't think there's any evidence that by using antiseptic agents, we're able to reduce infection. In fact, in some cases, because by disturbing your normal flora, we can actually affect the healing process, and some of the antiseptic agents are very, very toxic to good cells. So you may not want to use it too often, use it judiciously, use it maybe at the very beginning for people who have, let's say, a road rash. They fell on a very dirty floor, and you might want to clean that thoroughly. And then subsequent to that, you don't really need antiseptic agents. And then the other questions about the type of dressing. I think there's no one type of dressing for one type of wound. The selection of dressing is really determined by the amount of fluid. And if you have a dry wound, you use something that may be able to enhance moisture in the wound. If you have a wound with lots of fluid already, you want to find something that is highly absorbent to take away the excess fluid, so you don't get all this fluid leaking around. So the type of dressing in the study that we use for skin tear, we prefer that type of dressing because of the silicone interface, that we don't have to take off the dressing so frequently because of the foam layer, the absorbent core, and because when we remove the dressing, the silicone interface is able to reduce the trauma and reduce the amount of force required to remove the dressing. That's why we like the idea, but it doesn't mean that that's the only dressing we should be using.
Thank you. Bagaimana? Sudah puas, Pak belum? Okay. Okay, Prof. I am continuing the question from the participant. What is the better to use, the PHMB or the normal saline for the for skin tears treatment? And what do you think about the use of H2O2 for the skin tears?
I don't think there's anything wrong to use saline for cleaning a wound. I don't think we need to use iodine-based product or any other type of antiseptics, if I've mentioned earlier. There's no evidence that by using a strong antiseptic, we're able to reduce any risk of infection. In fact, I think the risk for toxicity is higher, right? So I think we need to think about and that's why we need to do comprehensive patient assessment to identify the risk portfolio.
Okay, thank you. Maybe any other question for Prof. Kevin?
maybe I'll provide a suggestion for people interested in skincare, and I'd love to hear more in person, hopefully one of these days, in terms of having a dialogue with you about skincare management. Because as you know, in Indonesia, it's warmer and people sweat, and some of the dressings may not stay on the skin very well. And also with the different skin color, and there's also a challenge for us to evaluate the quality of skin that is a risk for developing skin tear. So you can see that there's a lot of gap in terms of the research that we have been doing in North America, and we need some better information so we can contextualize, we can customize what we know to countries that is warm, to countries where people have different skin color and different skin tone. So that's another gap that we have identified that maybe we need to do more research about.
Okay, Prof. Prof, I have one question. Okay. How are the tips and tricks for skin tears care and dressing selection with elderly patient in category 3?
Right. So with the type 3 or category 3 type skin tear, you don't really have a skin flap there. So I think this selection is really determined by the amount of fluid coming out from the wound. As I said, if there's a lot of fluid, a foam dressing, you might want to add some calcium alginate for bleeding wound. And there's a lot of really good absorbent dressings, advanced dressing with beads inside that can absorb a lot of fluid. In most cases, from my experience, type 3 skin tear are highly exudative compared to type 1 and type 2, just because the amount of trauma required to take the whole skin flap away would cause the underlying damage to the tissue. That's why we expect more inflammation, more fluid coming out as a result of inflammation. So at least I think that's what I've been encountered in my clinical experience. Again, another area that we need to do more research.
Okay, thank you, Professor. Okay, this is the time is enough in 9 EM. And the conclusion, the elderly hair don't really get good care of the skin, and this is a challenge for Indonesian nursing about management skin tears and the future for Indonesian nursing. Thank you for joining today, Prof. Kevin, and see you in the next webinar, Prof. And thank you.
Thank you very much. Thank you for having me.
Yes.
Lovely to see all of you here.
Okay.
Bye-bye.
Bye-bye. Thank you, Prof. Okay. The next from the speaker from the Singapore, and the Jasmine Wu Chen. Hello, Jasmine. Okay. Still mute. Okay.
Good morning.
Good morning, everyone.
Long time no see.
Yes. Okay. Jasmine, hello.
Yes.
How are you?
I'm good. I'm good.
Okay.
Thank you for inviting me here today to share the time principle framework.
Okay. Yeah. Is this is the COVID-19 pandemic in Singapore is over? No.
Kind of. Now everything is back to normal, and there's more tourism coming, and yeah, medical healthcare is more busy now.
Oh. Okay. Okay. We are very grateful that you can be a speaker lecture into this webinar. Are you ready?
Yes.
Okay. I will read your CV. Just chat. Stomach and wound care nurse specialist member in Singapore Cancer Society, and education from University National Singapore Bachelor of Nursing, and Master Business Administration. Yes. That's it.
Yeah.
Okay. Okay. This from the work experience from Jasmine Wuchen, and this uh, experience, the experience operator. Okay. This is lecture pressure injury and speaker from the Medical Society Conference Singapore, July, and 15th Congress WCT Management Complication Stoma in Gerontic. Okay, Jasmine, this your the opportunity presentation 30 minutes. Okay, for the share from your slide.
All right. I think at the beginning, I need to verify with you
Yeah.
the experience that and the degree
Oh.
that I have is different as what you
Okay.
think. Yeah. Yeah. So
Sorry.
luckily today
Yes.
I did some of the introduction for myself.
Yes.
Yeah. So you will contact in the presentation. Okay.
Enjoy.
So yeah, should I start? Okay, so hi everyone. Happy to share with you of this topic, use time in chronic wounds. My name is Jasmine. I introduce myself first. I am a Taiwanese. My school, my degree is come from Taiwan, and in 2014, I started in Singapore. So my experience in Singapore and Taiwan included acute hospital, chronic hospital, and long-term care, include nursing home, home nurse. So currently, I have a company to provide nursing service and nursing consultation, especially on wound care, and to help the startup company to develop some wound integrate system and marketing and all that. Yeah. So to this topic, this is my discourse. Then my agenda today is first of all, start from how to define the definition of chronic wound, then go to mechanism of wound healing. Then the following part is wound assessment. This part, I'm not going to like normal lecture, the lecture they provide. I will prefer to use the term and combine with the image to show how to assess each of elements of time framework. Then the last part is how to manage the chronic wounds. Okay, the chronic wounds is kind of not healing wound in the certain period that we expected. In textbook, they will have more than 1 or more than 3 months. It depends on how you approach. Then you will see in the chronic wound, it will not same as normal like acute wound. It will follow by the wound healing process, the phase, each one or one by one. Sometimes 1 or 2, even 4 phases of a wound healing, it will appear in a chronic wound. And it could be because of systemic illness, age, or repeated trauma caused it. So the wound cannot heal in time, that we call. So, then the bacterial burden and the corrosive tissue and moisture balance. This is our key to how to manage the wound. We have to bear in mind the chronic wound. Actually, it can be turned to malignant degeneration, where some of the report it shows that it's 18 months since developing a wound, and some is even more than 20, 50 years durations. And just for example, as like right up, this photo, this is Magellan ulcer. This is very typical malignant degeneration from a wound. Of course, some of cancer, it also can show as a chronic wound, as like basic cell carcinoma or squamous cell carcinoma, or like myocarcinoma, like this photo. So this a typical wound, just like just now, Prof. Wu also mentioned about bullous pemphigoid. This is one kind of a typical wound. And for example, like zoster shingles in South Asia called, and vasculitis wounds, and PG, parodermal gangrenosis. So all these of a typical wound is quite easy to combine or get confused in the clinical with chronic wounds. So this part, as just now mentioned, the majority, we need to focus on the steroids treatment and combine with wound management. And the most easier to diagnosis of this is biopsy. Okay, so the skin structure that we know, we have epidermis to defend outsider bacteria or trauma. Then the dermis is contain our like hair part to moisture our skin, and the vascular, the vessels is to supply the nutrient and to maintain the turgor, skin turgor, for example, like collagen and fibrin and all that. Then the underneath of the dermis, that is a fat content. So all that have their own function. But once it have a wound, they will have 3 modes to work in wound healing. First of all, first intention, for example, like wound surgery, the surgery wounds. Then the secondary intention, like the wound is keep it open to do the dressing accordingly to let it heal subsequently. Then the other type of the wound healing is delayed primary intention. This is some of the wound, we will use it on infected wound. Then we need to make sure the infection factor has really rushed out. Then we proceed the following stitch out. Then in the wound healing, there's a few phases to work on wound. So from the beginning, they will have hemostasis. When the wound happened, the vessel has been cut off. So in the vessel, there were all the platelets and the fibrin, it will come to grab all the blood cells in order to make a clot to stop the bleeding. Then subsequent, it will move to inflammation. Once the wound is created, the macrophage and neutrophil, all these to protect and defend our body, it will come over to this wound and to do the macrophage. Then secondly, it will go to the proliferation. Proliferation is mainly to create the granulation tissue, and on the top, the dermis will start to healing to get it closure. Once it's done, it will move to remodeling. The remodeling is to let the collagen fiber to take place to enhance the turgor, skin turgor, and also try to back to normal skin. In chronic wound, always usually it will like go around in the inflammation and proliferation, and even more, some of the chronic wound, it will go into 4 phases in one wound. That is why acute wound, compared with acute wound, the chronic wound is more difficult to manage. Okay, from this photo that we can see on the wound side, actually it's like a wall. Our microphage neutrophil is trying to defend, but sometimes the wound, it cannot be managed. The antibiotics cannot penetrate into the biofilm. Okay, then the biofilm itself, it also will release some of the plastiers and to cause the secondary tissue damage. Okay, then bacteria itself, it also will release cytotoxin to kill the host immune cells as well. So what is biofilm? The biofilm is a bacteria. You just imagine it's a bacteria. It gather together. They form a layer. It looks like very slimy matrix to cover up the bacteria as a protection, as their home. So they start to generate. They have a more generation inside, and until this home is too small to them, they start to spreading, and they go to the other location and start another cycle. So the biofilm, the majority is because it can extract, it can release slimy matrix, we call EPS, to cover up as a shelter for bacteria. So here I would like to introduce one of the terms called wound hygiene. The wound hygiene come from oral hygiene. This term is mainly to indicate the biofilm it covers on the wound, and it causes antibiotics or our immune system wouldn't to work in functionally. So we need to clean out the biofilm in order to let the wound expose, and in order to treat the wound. So this is a photo where a wound is happened with debris. We can't truly see through the wound base. So after soaking, trying to remove that, you can see the wound base has released, and you can see the necrotic and slough, and you is formed here, and even can see some epithelium over here. Excuse. So let's come to wound assessment. First of all, the skin assessment. Excuse me. Excuse me. Okay. The skin assessment. From the beginning, we have to look at the wound surrounding skin. For example, like bruise, ecchymosis, all this, it will cause the skin more fragile, and it up to make our skin surface is not even and not flexible, and it's more easy to have a secondary damage if we didn't take care well. Then following is a swelling. As you can see, the skin will have tense and very shiny looking. Then it may have enlarged micro vessels that you can see over the surrounding of the wound, and that means the blood supply, they will have a concern that we need to look at. Then, like hematoma, the hematoma it means the blood is go into the dermis and subdermis, so it maintains this space until the hematoma start to soften. Probably majority is after trauma 1 week, it will start to soften, but it can be recurred if the friction or shear force is still there. Then the following information from skin at the surrounding here. Okay, to here, I need to bring up one of a concept, the inflammation during the wound healing, it will be happen, no matter whether it's acute or chronic. But sometimes chronic it can be very minor inflammation that not same as acute. Then the following is fragile skin and new skin. Why we need to look at fragile skin? It's because the fragile skin, it can it also is during the moderate phases, means before it complete, it still have a higher risk to have recurrence. Okay, so come to another one. From this photo, you can see that this is a children holding an elderly hand. Then you can see the skin texture is totally different. The baby's hand is more hydrated. That is why the senior purpura can happen, and it can be getting worse after trauma or to ignore the skin condition. And you can look at this skin, there's some bruise. It may have hematoma after the trauma. So like this, we have to go and touch it, palpate, and see whether have any induration within. Okay, let's come to wound measurement. Wound measurement, we will have to look at the location. We refer to anatomy position. Then the size from the length, we see by head to toe or proximal joint to distal joint. The width is from medial and lateral. Then the depth is from edge to the wound base vertically. Undermining is from wound edge to tunnel base. If that on the slide, right hand side, this photo. So we can record the wound shape, because sometimes it will keep changing, and especially if the wound age is irregular, we have to refer to the anatomy and the factor cause the wound. And sometimes it can be cause of immunity, cause the atypical wound just now I showed. Then the other one, we have to assess the characteristic of the tissue. Usually I use by RBY scale or by percentage, like how many percentage of slough, and compared to black tissue, necrotic tissue. If we want to manage a wound, a chronic wound, we have to start from understand how is the wound characteristic. So that is why TIMES principle framework is a way for you to assess wound. Okay, so that's from the time tissue. The tissue, we have to look at the granulations, slough, necrotics, necrosis tissue. So these three we call RYB. So in the record, you may see some record use RYB 2 to 1 to 7. This kind of way to show how the wound it is if we don't have any image to support. Okay, so the tissue itself, right? We have to see whether it's the wound, the tissue, whether it is improving. Like we have to identify the age, wound age. then the epithelium, that will be a key point to know how big is the wound. And on the tissue, usually you may see some of the fibrin. The fibrin is like a very jelly form cover on the wound. That is we so-called we may see it as a biofilm. Although biofilm is it may not visible in the wound, but when this fibrin happen, usually I will treat it as a biofilm. The fibrin treat it as a biofilm in order to let me to more strongly need to clean this wound thoroughly. And we have to look at the tissue whether it's hypergranulated. Like this is higher than skin level. So if this area is continuously we maintain the same dressing or same products, expected the granulation will more higher. So what is the difference with hypergranulation and granulation? Once the hypergranulation is overgrowth, the tissue, the skin itself, it cannot cover. So the tissue, that means we will just maintain at the edge of the granulation. So you cannot fully cover, means the wound process will get taking longer. Then it will cause a chronic, you will help that the chronic status maintain longer. Okay, then sometimes you may see the wound with tendon, ligament. So all this, you can see this, the tissue is more shiny and with silver color. This is more healthy as like this area. This is a healthy tissue, healthy ligament. Then when it becomes rough, it will turn to yellowish like this. Okay, so from here, you can see there's different type of necrosis. So right hand side, this one is a necrotic skin. You can see the tissue is fully yellowish without blood perfusion. And in between, they still have some tissue and the skin is survived. Means this necrotic tissue, it only makes certain level of the cutaneous dying off. So it usually is because of infection underlying, like maybe have sepsis. Cause the cutaneous necrosis. And this two, you can see, is a gangrene. The gangrene is because the tissue dies off with low blood supply or lack of a blood supply. We can consider the peripheral. Some of the major vessels has artery has occurred. So it causes whole circumference tissue, even include the bone, drying out because lack of blood supply. And sometimes you may see some gangrene, it combined with very massive odor or discharge is processing. I will treat it as gangrene with acute status. Majority is because during the dry gangrene, they have some bacteria infected this area, so it causes secondary infection. Okay, so this photo shows the fat tissue. This is actual and healthy tissue. It's come from a skin tear. Then if the fat necrosis, you can see it will turn to semi-transparent. Okay, so like all this is a slough. We need to remove it in order for to shortcut the wound healing. Okay, so come to the second element of time, inflammation and infection. We need to figure out whether this wound is infection or inflammation. Inflammation just is what I say just now. The inflammation is, it will follow all the way of a wound process. So inflammation is just like this. It's very minor. It may have pigmentation combined with. Then spreading reddish will be like this. It's more aggressive and trying to extend from the wound edges. Then the other one, we need to observe whether have any warmness or heat. And as you can see, this area, they will have some marker over here. This is for subsequent when we look at the infection, whether to observe whether the infection is under control or not. Yeah, followed by this marker. Then you can see it, you still can see the wound still, the skin still shining and tense, means the leg is still swelling. And sometimes we will do palpation to check whether have any induration under cutaneous. Then you might see to check the induration. Sometimes we will do some penetration to check whether it's a prurient discharge or clear fluid, if without any ultrasound. But this is a very tricky procedure that we need to under doctor's assessment as well to make sure that there is a floating sensation under the cutaneous. Otherwise, it will cause patients harm as well. Then the other one, this photo, it shows infective granulation. The granulation, usually we would see granulation is a healthy granulation. It is a healthy environment in order for the granulation to generate. But sometimes when the infection factor is still in the granulation in the wound, it will cause push. The granulation is more active. So kind of overactive within and combined with some slough. And as you can see, the surrounding the skin, you will have some tension. It still has tension. So like this kind of picture, you have to keep in mind. You have to check whether have any undermining, unexposed undermining. Like this wound, it has a hematoma over the circumference area. So secondary, it requires secondary debridement or to explore, to drain out all the pus. Then refer to 2016 International Wound Infection Institutions. They lie out the phase of an infection. From this photo, we can see the wound, it can go to these 5 phases. So usually in chronic wound, we will focus on local infection, spreading infection, and systemic infection because that will be more highly concerned that we need to use antimicrobial agents. Okay, so come to moisture imbalance. So moisture imbalance, we have to observe the exudate. The exudate, we have to look at every time, every time of a review, you have to look at the amount and color and texture, like prurient or clear fluids, and even odor. So you can see from the wound area, the wound edge, is there any maceration and even some of the hyperkeratosis? It could be cause of friction and the discharge doesn't manage well and all that. Then if you look at this photo, you can see some of the scab, even the tissue is dying off because the wound is too dry. And you may check on the dressing itself, whether it's fully soaked or less of salt. That even fully soaked, and you can see the wound base itself, there's a lot of discharge and fluid still maintained over the wound base. And the induration, some of the pus, when you drain out, whether it's prurient, hemoserous, or subsequent dressing, subsequent discharge, you can see whether it's getting more purulent or semi-purulent in the discharge. And when you, because currently what we use the dressing, right, is mainly to keep the wound is longer in order to let the wound healing work faster. So sometimes it may confuse in when the dressing track into when the discharge track into dressing, it shows in different color. So these have to refer to how long you keep the dressing in the wound, and you check on the process and to figure out whether it's going to move to chronic or infection status. It's like all of these, you can see there's different color and from the dressing outlook. Okay, so like this is very common because this is a pickle dressing. Pickle dressing, you can keep about 7 days. So the dressing, just imagine if the discharge is tracked in the foam dressing for 7 days, then the discharge the color will change if it contains with blood. Okay, then this is a acute wound. So this wound is the discharge, you can see some of the blood content, and subsequent is more yellowish, means our body fluid in this discharge. Then or some like back dressing with acute bleeding, then it may have like this kind of feature. Then you can see some of blood, even fresh blood, it come out from the tubing as well, from the dressing, edge of the dressing and tubing as well. Okay, so come to age. How to observe the age? First of all, is free or intake of the age. Then the hyperkeratosis. Okay, some of the hyperkeratosis, it will cover up the wound bed. So like this kind of overgrowth skin, right? We need to expose, we have to trim it, and in order to expose the wound bed. Why? Because chronic wound, we have to consider there's some bacterial colonization, critical colonization, or local infection. The picture is not same as acute wound, because acute wound is like more angry look. But chronic wound, it can be very silent, and you can. That is why chronic wound is more difficult to manage. So when we look at the hyperkeratosis, we have 2 points we need to see. First of all, the friction, the serum force, whether it's still not dissolved. Then the other one is the wound bed. It doesn't be exposed. So that is why we need to know how to observe the hyperkeratosis. Then epipode, majority is at the skin edge, then eroding. Some of the textbook they will call rolled skin. So when wounds happen, especially in the major or bigger wound, that you can observe the skin rolling into the wound. it will start from after 3 weeks, one after the wound have developed. So before that, we need to bear in mind, we have to try to clean up the wound base to make this wound bed is clean and ready to granulation and ready to that the skin migrate to the center. So like this wound photo, you can see the center has a lot, still have 80% of a slough, and even have some skin necrosis haven't removed. So you can see this area, because it's more clear, then the skin is start to ruin. But because the center haven't ready, so it will cause the skin uneven. So if uneven wound, it will make your dressing couldn't confirm well, then we have more limited dressing product to use. And the other one is more difficult to clear up the infection factor if it's rolling up. Sometimes it will crowd together. Yeah, so when we see this sign, we have to speed up our clearance of the wound bed, try to clear out all the slough as well. Then the other one, the ages, we have to observe whether it's irregular age or regular age. Some regular age is because you can see this wound bed is very static. This is very typical chronic wound shows. The discharge will be a lot, but you can see the wound bed without any granulation, and it's very flat. And you can see the color of the tissue is very pink. Yeah. So, that like this, we have to observe, because this is at the bottom area, we have to observe whether have any fecal contamination, urine contamination, and whether the dressing is applied in right, is confirm the wound and cover the wound, and whether has any medical device to enhance, to protect the protect from friction or shear force. It's like AMHS pressure relief cushion. So yeah, then you can see the center of this wound. Where is the wound age? From this photo, you can expect the wound is like this big. And subsequent, when the wound is start to heal, there's some epithelium is grow. So it's coming to here. Then you can see the center here, there's some fibrin. Then the red color is the raw tissue. So in between, there's a pink color. This is epithelium. So the wound age, the current wound age is this big. So this is how I identify a wound. Okay, so from this photo, you can see some area there's a pressure injury happen. This is secondary pressure point. So from every time when you look at the wound, we can collect a lot of information, even though you are not in the clinical to take care of patient. But from this wound, it shows there's some need and some prevention we need to carry on or to enhance. Okay, this photo I want to show everyone is in the wound, right? Once it's broken, compared to previous injury, it will only can recover 70 or 80%. And the skin turgor, it will become weaker. And it also, because once the wound is getting deeper, go to underdermis or damage the dermis, there will defect of the sebaceous glands. It will lack of moisture as well. So when wound is happen, if its recurrence happen, you can expect the wound, this area, even though it healed, the skin will be fragile compared to the surrounding normal skin. Yeah, so that is very important that we look at all these wound process and to maintain it until modeling phase, to make it in good status, more flexible new skin, in order to prevent the recurrent wound. Okay, so till now we have already finished the times wound assessment framework, but I would like to share with you. I will more focus on. I will put the times with as S, and this S is more. Sorry, the S means social support. The social support, it can be to care about, to cover about family financial support or patient's emotional support. This is also will affect the wound healing, and we need to look at that because there's some paper shows that the chronic wound, if more than 3 months, it will bring patient into a depression status. So the sense of the belonging and the proper food, the dressing products, and inadequate nutrition and medical device, all of this, it need more support to the patient in order to let the times to work it better and to shortcut the wound healing and to prevent chronic wounds. So after this, I assume that you already know how to look at a wound and to find out the different part of a characteristic of the wound. And from here, that is to help us subsequent when we look at to review our dressing product, whether it's capable or we need to change it, or we need to find out another way or more quick, faster way, for example, to do the debridement to increase the wound healing speeds. Okay, so I would like to share with you the last part, the how to manage a chronic wound. Of course, from the beginning, I would like say, if start from acute wound, we were trying to keep the time in mind in order for the wound can heal in time. But sometimes it may not be happen, and sometimes when you receive the patients, these cases, it has become a chronic status. So how to make a chronic wound to be acute status, that is a very important point that we need to look at. So I provide these 3R assessment. First of all, review wound by times principle. We use the time to look at all the category and find out all the characteristic of the wound and what's the reason and what's the possibility to cause this part of a characteristic, and try to sort out. And in chronic wound, there's some there's some paper to support that acute management is a key, because some of the chronic wound you may not able to see the very active granulation tissue in order for you to expect and assume that the acute it can be how many, especially from the first time view. So acute management, it come into the picture. Then the other one, when you doubt or you suspect this chronic wound with any possibility cause, as for example, like malignant change or dermatologist issue, then you have to suggest to perform biopsy in time, like especially like chronic wound more than 3 months, and the wound size is increasing with standard treatment. And through my personal experience, how to differentiate, how to identify the wound is normally without any systemic illness cause the wound, then I will look at the wound photo. As right hand side, this photo, you can see some of the dermis epithelium in the wound edge, in the wound base, and you follow the repeated assessment, you may see some of the epidermis. It can come off, it can grow, but sometimes it will break down again. So like this, if it come into your picture, then you have to concern, see whether have any malignant change or any dermatologist issue into your concern. Yeah. Then the second is to reactivate the wound healing. So as just now what I said, the chronic wound, sometimes you can't see very active granulation. So how to make the wound bed is more active? One, you have to do wound hygiene. Try to remove all the stuff and try to remove the fibrin. That is a very important key to let the actual wound to expose. Then the second, if you need to do debridement, then you have to seek as your ability or seek doctor help to remove the slough if necessary. Sorry. Then the third part is to remove possible potential factors cause the wound healing delay. So for example, like just now what we say about like immunities, like and some of like cancer, chemotherapies possible, because after chemotherapies and because the immune is suppressed, then like if environmental factor, for example, like some of the chemicals, I even encountered one of the patient that the chronic wound is because she is a cleaner. So every day she use her hand to clean everything. So she also used some of the chemical cleanser. So her hand, it become fragile and repeat the inflammation, and subsequent it become wounds. So like all these patients, we need to figure out and find out what's the reason cause the wound cannot heal. Then try to remodeling and find out the solution for them in order to shortcut the wound healing and to maintain as well. So this is all about today. I would like to share with you, and hopefully you are enjoy of my presentation. And if you have any question or want to contact me, I leave my email here. Okay, thank you very much for your listen.
Thank you, Jasmine, for sharing your knowledge. Very interesting, very case and detail for the chronic wound assessment and management for wound chronic. Okay, are there any questions for the participant? For speaker two, Jasmine Wu? Oke, kalau nggak bisa bahasa Inggris, pakai bahasa Indonesia nggak apa-apa. Saya translate.
Halo.
Ya,
Yes.
halo.
Ya, halo.
Bisa
Selamat
dibuka
siang.
kameranya?
Oh, no.
Oke, spotlight.
Halo, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. First, I have a question for Jasmine Wu.
Yes.
How to treat wound if one have hyperkeratosis? Second, how to treat wound if wound have bone exposed? And the last, please give me a trick how to bestow necrotomy. Just like that. Thank you for this time. And
Okay. Sorry, I didn't catch the third one. The third question. I try to. The first question: how to treat the hyperkeratosis? Okay.
yeah.
The keratosis, right? Just as what I say, the keratosis is happen when the friction and shear force happen. So it's a sign to telling you that this wound is under pressure and it's moving. So from the hyperkeratosis itself, we have to see where is the location. If on the toe, then we have to think about the footwear offload. If on the buttock, it's because whether is patient is sitting position or keep moving, like Parkinson's disease, you will keep moving, it can't stop. So like all of this, then we need to choose some dressing is more thicker with foam, like foam, and it can provide more cushioning and to balance the pressure. And the other one is pressure relief cushion, like air mattress, or like when they're sitting, they should have some of a foam or dressing, because currently there's a lot of cushioning mattress. It provide for sitting, for lying, or different material. This part, if go around the wound care, right, you may pay attention whether, because a different location, different region have different resources. Then you can have to find out and to research which one is more good for your country, because different weather, different season, it can cause, and different financial support as well. Okay. So the other one, the other question is how to expose the wound. Am I right?
Sorry. How to treat wound if wound have bone exposed?
Bone exposed. Okay. So the wound bone exposed, right? We have to look at two things. First of all, if the bone exposed means have a potential osteomyelitis. Okay. So this part need to look at the history and see whether have any resources or any diagnosis has happened. Because what's the difference with wound without bone exposed is because the osteomyelitis, it can we just expect the bacteria get into the wound, get into the bone. So when doctor use antibiotics treatment, it need take longer time, like more than 6 weeks treatment, antibiotics treatment, in order to treat the bacteria in the bone. Otherwise, it also will affect the outer the wound, the tissue unable to cover, and even cannot close the wound. Yeah, so combined with antibiotics is important. Okay. And the third question is,
please give me how to best necrotomy.
Sorry?
Please give me trick to the best necrotomy.
Necrotomy?
Okay, yeah.
I cannot get what's the necrotomy that you mentioned.
For example, the tissue have necrosis.
Yes.
How to treat it?
Or how to treat it? Okay. If we look at the tissue, right? I always tell my patient we only need red tissue. Just now what I mentioned, RYB, right? So we use the tissue color to indicate the by colors. So we only want the red tissue. So Y and B, yellowish, black color, this is what we don't want. Yeah, so we can use some of like hydrogel to soften, and even it depends on your availability that in your region, or like alginate AG, hydrofiber, all these, it can soften because it absorb it control all the body fluid, exudate to moisture the necrotic area so that it melt and degenerate secondary. But of course, it will take time. Compared to sharp debridement, of course, it takes time, but it's safer. It's easy and more safer used in community and long-term care sector. Yeah. So yes.
Okay. Thank you very much, Miss Yasmin Wu.
Welcome. My pleasure.
Thank you. Maybe any question from the participant? Again.
Good morning.
Yeah. Morning.
On camera. Okay.
With me, Karta.
Yes.
I just have one simple question. As a nurse, for the especially for this case, for the chronic wounds, how long time? As we know, the chronic wounds, we need so many times to manage, and how long time we need as a nurse to evaluate for the, I mean, in every month of in every weeks to
in terms of review, is it?
Yeah.
Okay.
For this case, yeah.
Okay.
Thank you. Yeah.
Okay, thank you for your question.
Yeah,
okay, this question is very nice and it's very practical. To be honest, in the acute wound, right, I will expect the wound, if under infection, the majority have local infection, even more systemic infection. So usually I will gauge is about 6 to 8 weeks, means 2 months, within 2 months. This is acute wound. So after 8 weeks, we have to look at you might need to compare with the initial wound and subsequent wound photo. If you have keep, I will strongly suggest to keep the photo. You just check at the photo, because sometimes when we walk in very busy, right, can't really remember the photo. The last image is how different it compared to currently. So we have to look back of the photos to compare. Then after 8 weeks, 2 months, then you have to look at the wound itself. If the wound, the tissue, first of all, I will look at the tissue. The tissue, if the granulation tissue, it become flat and not active, then we have to consider what's happened of the granulation. The granulation is indicate the nutrient in the wound. Also indicate any pressure. It could be a pressure, the stress in the wound. So the stress maybe come from infection. So when we look at this, then we have to whether we need to change our dressing products. Usually the dressing product from the beginning, from acute wound or chronic wound, I will gauge it for 2 weeks first. From the first 2 weeks, if the dressing doesn't work very fast, or even in the 1 week, you can see some granulation doesn't move, or the age doesn't move, and sometimes it becomes worse, getting increased, then we have to see what's wrong with the dressing, what's wrong with the wound. Then if the wound is getting static, then I will try to either use the forceps, like normal forceps, to stimulate, the wound bed.
Necrotic.
Yeah. Yes, not just necrotic. Sometimes if the granulation is very flat and very pinkish, then I will try to use the forceps to scrape, like kind of make some of a trauma, but it's minor trauma, yeah. Small trauma, to see whether have blood flow come out, like blood oozing, but don't make it too bloody, yeah. It's just oozing, yeah. Then because the cleaning doesn't take the place, doesn't really clear better, you might need to consider whether use some of the solution with antimicrobial agents like hypochlorite acid, or in traditional way, we will use hydrogen peroxide to try to remove the surface, to clean up the surface. Yeah. Then look at the dressing itself. Sometimes dressing material, it can cause, especially when the patient with more like elderly, the immunity is not so well, and maybe they still taking a steroid. In my experience, I find out because in worldwide, usually we have two model of a dressing, right? One is iodine-based dressing. The other one is silver-based dressing to control the wound infection wounds. If the immunity is poor, the iodine-based dressing, it seems like overstimulate in my experience. So from the beginning, maybe the iodine, usually in the cost concern, iodine-based dressing usually is cheaper. But sometimes because it is too stimulate, too strong to the wound, so I will change to silver. Yeah. All this concern how to change your dressing always after two weeks duration. Normally my treatment will be, I will stick on one antimicrobial agent dressing after 2 weeks, then to see whether one need to carry on this dressing, or whether we need to change. Yeah, that is how I plan for like chronic. Then to the review, right? It depends on your cost and manpower. If the manpower, like for example, in the acute hospital or the hospital itself, there's more nursing manpower to carry on, to do the dressing. Then I will leave it to the general nurse, the ward nurses to do. Then I will take from the beginning every weekly or 2 weekly, subsequent monthly. Usually I won't take more than 2 weeks, to be honest. But in the nursing, like in the community home care basis, right? Because in Singapore, this part patient need to pay by their own pocket. So if the care, they're able to carry on the dressing, and you expect this one cannot be work very fast, sometimes we'll move to monthly. Yeah, it depends on how is the wound and what's the wound about. like cancer wound, we
Yes.
cannot expect it heal,
That
right?
depends
So
on the large of the wound.
yes, yes, and the condition it need to look at some of a patient. The majority, the wound cannot heal is because of nutrition, like those malnutrition, elderly, or their food has inadequate nutrition concerns. Then the nutrition part play the majority part. Then to the wound management, I will put it at a secondary to support the wound instead of the target will be support, maintain the wound instead of let the wound have bad progresses. Okay.
Thank you.
Welcome.
It's clear. Yeah.
I can't hear.
Okay. One more final question.
Yes.
Yeah. One last question for Jasmine. Are there any questions from the participant? Okay. Not yet. Okay. One question, Jasmine, from me. Maybe share how is the chronic wound care in your hospital? Maybe nurse in Indonesia can apply it to the patient, the respective in hospital.
To chronic wound, right? Because currently what I serve acute wound, acute hospital. So acute hospital, the majority is to control the acute systemic infection instead of let them to have leisure time to stay in the hospital. Once their majority sepsis has come down and under control, most of the time they will be transferred out. So, or discharge or transfer to like community hospital, nursing home to carry on the wound care. So in the chronic wound picture, right, the expenses, it may not be like dramatic high because it has been chronic. What my goal for the patient with limited timing, maybe within a week. So you see, in 1 week, how to make a chronic wound to be active. What I can use is more stronger method like povidone iodine dressing at the beginning. Now, then subsequent maybe I will give information like memo to provide the subsequent care and when to refer to doctor or when to refer to subsequent specialty. They will come into the picture. So to the expensive, right? Actually, for chronic in my current service, there were only like 20%, 30% cases with chronic wounds. But sometimes the chronic wound cannot be just one in one patient. It can be one patient have multiple chronic wounds and it has followed the patient for a year or for months. Yeah. So the causes in the chronic, right? In my acute hospital, that would be little. But I know and I believe in community hospital or long-term care, even though home care service, the percentage will be go to more than 50.
Okay, thank you, Jasmine. I hope you all the participants you have the topic and material
Yes.
from the international speaker and you. Oh, anyone question?
Yes.
Jasmine?
Question. Para
Okay.
Anwar.
This is the finally question from Peter.
Sure.
Okay, you on camera?
Negative pressure for wound care actually is the absorption of
Sorry, your voice. The problem. Yes, good.
Clear. Okay. I just sharing about the negative pressure for wound care, especially with if I find the wound negative. Wound with the chronic. There is many pus on the wound. Actually, it will be lost many electrolyte and protein. It will be high gut test or many jasa itu apa ya? For the patient to it will be lost many electron and protein. Ya, hearing is it clear?
Gimana Pak? Bisa pakai bahasa Indonesia, nanti saya coba luruskan.
Gini loh, pemakaian negative pressure pada luka-luka kronik itu akan berdampak pada kehilangan elektrolit tubuhnya, proteinnya, yang akan berdampak pada jasa yang mereka keluarkan dan biaya yang akan dikeluarkan terlalu banyak, sehingga mereka membeli protein, albumin dan sebagainya untuk mengembalikan kondisinya. Itu dampak dari negative pressure. Gitu aja sharingnya.
Oh, ini pertanyaan atau minta sharing terkait dengan pemakaian? Oke, Jasmine. How about you the application for negative pressure wound therapy?
For chronic wound?
Yes, because from participant effect from the negative pressure wound therapy, the low for the electrolyte and protein, maybe tips and trick for the apply negative pressure wound therapy for the nurse in Indonesia.
Okay, it depends on what kind of negative pressure wound treatment you concern and the cost. Yeah, so the chronic wound, because it has been chronic, right? Means patient is suffering in wound for a while, and maybe the financial it doesn't able to take into the place to support this negative pressure wound treatment. As I know, there are some area still using modified negative pressure wound treatment, especially in the hospital setting. They can use the word suction to provide the pressure. Yeah. Yes, chronic wound. If you want to consider that the wound have active granulation, negative pressure wound is a way. The purpose is to just imagine the negative pressure is to suck out the discharge, and it will provide pressure, and it also will enhance the osmolality to let the discharge and all the element the discharge come over, so it can indirectly to support the pressure, the vessel, to provide the circulation. So yes, chronic wound it can use used by negative pressure wound treatment, but you have to be careful because it is a chronic, and if you don't look at the issue, it causes the chronic factors, all those like intrinsic factors or extrinsic factor, that medication cannot take place, or radiotherapies. So the tissue turgor is not there, vessel is not there. If you use negative pressure wound treatment, it may not take place. Negative pressure wound treatment is used when the blood supply is ready. Yeah, so if you want to use the negative pressure wound treatment to enhance the blood supply, it's doable, but it will take time. So need to consider the financial part. Yes, that's how what I suggest.
Okay, thank you, Jasmine. I am translating for the partisipannya. Okay. Begini Pak, untuk pemakaian NPWT itu harus dilihat dulu dari kondisi luka kronisnya. Lihat isunya, isu bukan gosip, tisu bukan yang tisu di Indomaret itu ya. Isu yang ada di dalam luka itu masih nekrotik apa belum, sudah mencapai yang merah apa belum. Jika sudah, silakan dipasangkan negatif pressure wound therapy sesuai dengan standar operasional prosedur yang ada di rumah sakit atau hospital ataupun dari standar operasional prosedur dari alatnya. Jadi kalau untuk mungkin katanya kalau ada kontraindikasi di sana itu bisa tidak boleh dipakai karena pada pasien-pasien dengan luka kronik dan luka bakar yang mempunyai komplikasi di ginjal nanti akan bisa menyebabkan kekurangan cairan dan elektrolit, bahkan protein dan albumin. Begitu Pak. Oke.
Okay. Thank you.
Okay, Jasmine, thank you for
sharing
topic. Times is up. Thank you for
terima kasih.
Terima kasih. And
Okay,
webinar,
bye.
Jasmine, thank you. Bye. Oke. Untuk selanjutnya ini karena dari pembicara ketiga ya menginformasikan Bapak Ibu ya peserta hari ini menginformasikan di sana ada badai, di sana juga ada storm. Biasa kalau di Amerika Latin itu terjadi hujan badai sehingga koneksinya itu tidak bisa sampai sekarang, koneksi dari Janaina itu belum bisa. Kemudian kita akan tunggu dari si pembicara tiga ini Profesor Vanessa belum bisa hadir, kemungkinan besar nanti akan diputarkan dengan videonya. Besok nanti linknya akan diberikan kepada Bapak Ibu. Kemudian memang sedikit informasi, saya lihat apakah di sana betul terjadi badai, ternyata saya lihat di sini juga benar ya Bapak Ibu. Hujan lebat di Brasil ya. Saja bilang di sana sudah -2 dengan hujan badai. Sepertinya koneksinya tidak bisa sampai di sini. Jadi nanti saya akan kirimkan link untuk bisa melihat materi dari beliau. Untuk selanjutnya saya akan berikan ke MC. Ya, karena terkait teknis dan koneksi, karena memang Zoom ini perlu sinyal yang kuat, bahkan dari negara terbit matahari ke terbenam matahari. Kalau sekarang hari Minggu, di sana masih hari Sabtu malam. Oke, Mas Fauzi. Halo, Mas Fauzi.
Halo, iya Pak Burhan.
Oke, saya amanahnya sudah saya selesaikan ya. Untuk menjadi moderator, silahkan bisa diambil alih lagi untuk MC-nya. Terima kasih. Saya akhiri. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Baik teman-teman semuanya, kita sudah tiba di penghujung acara. Karena memang salah satu pembicara terakhir kita hari ini belum bisa bergabung gitu nggih. Belum bisa bergabung karena kendala jaringan dan cuaca. Dan mungkin kita akan menunggu, khawatirnya terlalu lama dan lain sebagainya, dan kita putuskan hari ini beliau belum bisa bergabung dan mohon maaf untuk teman-teman semuanya. Seperti itu, nggih. Nggih, Bapak Ibu sekalian, kita sampaikan di layar Bapak Ibu sekalian ada link absensi di hari yang kedua dan nanti juga ada link tentang form sertifikat gitu ya. Nah, nanti silakan diisi sambil mengisi gitu ya. Kita mau bagi-bagi door prize ceritanya nih. Nah, ini yang ditunggu-tunggu teman-teman ini ya. Yang tadi di awal sudah kita sampaikan kalau hari ini ada 4 voucher OVO gitu ya, masing-masing voucher senilai Rp100.000 gitu ya. Nah, kisi-kisinya sama dengan yang tadi, dengan yang kemarin, yang tadi saya sampaikan juga, yang bisa merangkum untuk materi hari ini. Jadi hari ini ada 2 materi ya, berarti ya, ada dari Prof. Kevin dan juga Jasmine gitu ya. Nanti silakan dari 2 materi ini dirangkum, ringkasannya seperti apa disampaikan, nanti akan kita pilih. Kalau nanti pesertanya yang ikut kompetisi ini kok lebih dari 4 gitu ya, maka akan kita pilih 4 terbaik. Kalau ternyata yang ikut cuma 4, ya alhamdulillah langsung dapat hadiahnya seperti itu. Nah, kalau ternyata nanti kita tunggu kok tetap tidak ada, wah ini hanya satu orang yang berani atau 400.000 nanti kita bagi jumlah orang yang berani seperti itu. Baik, mungkin teman-teman semuanya yang sudah menyimak 2 materi bisa sambil persiapan, sambil kita infokan, jangan lupa untuk mengisi link daftar hadir tadi ya, dan juga link sertifikat. Nah, link sertifikat. Dan tadi kita juga sampaikan kalau ada hadiah buku nih ya dari Malaysia, nanti hadiahnya juga akan gratis, free ongkir sampai ke rumah teman-teman gitu ya, free ongkir sampai ke rumah pemenang ya. Bukunya cuma 1, senilai harganya Rp1.000.000 buku ini ya, memang sangat mahal sekali dan sangat bagus sekali buku ini nanti ya, dan free ongkir sampai ke rumah pemenang. Nah, ini mungkin bisa disimak pemenangnya gitu ya. Ini langsung saya kasih tahu. Jadi yang berhak membawa pulang bukunya nanti, yang berhak menerima bukunya, yang pertama saya mau apresiasi untuk yang hari ini gitu ya, barangkali ada yang hari ini berulang tahun gitu ya. Yang hari ini ya, hari ini tepat tanggal 5 Februari 2022, saya pengen ngasih hadiah khusus untuk peserta yang ulang tahun pada hari ini. Nah, silahkan nanti yang ada langsung ini ya, dibuka mikrofonnya, saya sedang ulang tahun gitu ya. Nah, hadiahnya cuma 1, kalau ternyata yang ulang tahun ada 2, maka akan kita lombakan gitu ya. Oke, baik, ini saya buka view semua galeri pesertanya, akan kita buka. Monggo silahkan teman-teman semuanya untuk hadiah voucher OPPO senilai 100.000, ada 5 voucher, silahkan bisa membuka mikrofonnya, membuka kameranya. Ayo, siapa nih yang berani?
Saya, Pak.
Pak Airlangga Arif ini ya?
Ya.
Yang dulu. Baik. Saya cara dulu Pak Airlangga Arif. Ada lagi setelah Pak Airlangga Arif yang nanti pengen mencoba menyampaikan ringkasan. Saya data dulu nih, siapa cepat dia dapat, gitu ya. Nanti setelah ini kalau ternyata lebih dari 4 kita lombakan. Nah, ternyata cuma ada 2, ya udah. 400.000 kita bagi 2 gitu ya, 1 orang dapat 2 voucher. Ini mana ini? Tidak ada yang berani untuk menyaingi Mas Airlangga ini. Yang lain ada ringkasan 2 materi hari ini gitu ya. Tidak ada. Mungkin yang lain bisa dipelajari gitu ya, materinya tadi dipelajari dulu, dicercer dulu nanti apa yang mau bicarakan, yang mau disimpulkan 2 ini. Silakan kalau gitu Mas Arif Airlangga, saya persilakan untuk menyampaikan kesimpulan dari 2 materi hari ini, Mas Arif. Silakan.
Terima kasih atas kesempatannya, Mas Rahmat Fauzi. saya ingin mencoba memaparkan kesimpulan dari dua materi tadi. Pertama dari materi Pak Kevin ya, dari Pak Kevin tentang kurang lebihnya ada tentang untuk bagaimana kita sebagai perawat melakukan asuhan keperawatan terhadap dan klasifikasi pada luka skin tears. Skin tears itu memang ini benar-benar fresh banget di di kalangan perawat-perawat Indonesia juga belum terlalu terpaparkan ya. Dan tadi si skin tears itu ada beberapa klasifikasi, ada tipe 1, tipe 2 dan tipe 3, di mana tipe 1 itu di mana si kulitnya itu masih full, di mana kalau kita balikan lagi itu masih bisa menutup luka yang udah robeknya itu. Dan yang kedua ada yang tutup parsial. Jadi robekan kulitnya itu masih ada, tapi ketika kita tutup itu masih belum menutup secara belum menutup keseluruhan luka. Itu yang parsial. Sama yang benar-benar si kulitnya itu benar-benar terkelupas, itu yang tipe ketiga. Dan pada sesi beliau tuh Bapak Kevin itu mengatakan kalau ada dressing adhesive dressing yang memang benar-benar bagus, itu kegunaannya juga buat menjaga kelembapan si luka itu sendiri, sama terus untuk yaitu adhesive dressing itu tetap si skin tears itu healing dengan benar lah, dengan baik gitu. Itu kurang lebihnya untuk yang materi pertama. Dan yang materi kedua dari Ibu Yasmin Wu, terkait tentang bagaimana kita memanage dengan baik perawatan pada luka kronis. Seperti kata beliau tuh ada luka kronis yang disebabkan oleh maligna seperti kanker, dan juga ada beliau juga memaparkan beberapa proses penyembuhan luka, yaitu pertama ada hemostasis, di mana akan proses ke proses inflamasi, dan kemudian ada yang namanya proliferasi. Proliferasi adalah proses di mana si agen-agen penyembuhan itu kayak pembuluh darah, granulalisasi itu berproses di situ, dan terakhirnya kayak reform lagi lah, jadi ke jaringan yang baru gitu. Itu yang ada empat proses penyembuhan. Terus ada yang namanya biofilm, di mana saya juga baru tahu ini si agen bakteri itu yang menempel ke luka itu dia jadi ada beberapa jenis bakteri yang bisa menempel ke luka, dan mereka akan bertransformasi atau membuat matriks, namanya matriks ekstraseluler epidemeric substance. Nah, itu dia itu buat melindungi si bakteri itu sendiri, untuk melindungi mereka dalam pengobatan. Jadi antibiotik itu tuh nggak mudah untuk menembus si EPS ini. Sama yang terakhir juga yang paling terpenting untuk kita sebagai perawat itu ada 3R dari beliau untuk memanage luka kronis ini, yaitu R pertama itu yaitu kita harus assessment lah, assessment dengan assessment luka dengan time, kayak itu tisu. Jadi kita lihat dulu jaringan lukanya seperti apa, terus ada infeksi atau enggak, I-nya itu, terus ada M-nya juga moisture-nya, sama E-nya itu edge itu kayak pinggiran lukanya seperti apa. Pokoknya kita identifikasi head to toe juga. Jadi bagian R yang pertama. Yang R kedua itu bagaimana kita sebagai perawat untuk menangani si luka tersebut, seperti kayak apakah si luka ini masih bisa didebridement atau seperti pembuangan nekrosi, agen-agen yang memang menghambat penyembuhan luka, seperti ada sel-sel nekrotik harus di remove, necrotic removal, necrotic tissue removal, seperti itu. Dan yang terakhir adalah R, yang dimana di faktor extrinsic seperti chemical atau environment juga kita harus perhatikan, seperti ya mungkin juga seperti kayak faktor historical pasiennya itu sendiri. Misalkan pasiennya juga punya diabetes atau apa, kita juga tetap ada pengobatan diabetes apa seperti itu. Ya mungkin seperti itu yang bisa saya tangkap sih konklusinya.
Sudah sangat panjang, sangat lengkap sekali, Mas Arif. Oke, ini kita save dulu, Mas Arif. Barangkali masih ada teman-teman yang pengen ikut berkompetisi dengan Mas Arif ini ya. Silakan buat teman-teman semuanya. Kita pengennya ada 4, kalau bisa lebih nanti akan kita kompetisikan. Kalau sudah ada 4 ya kita bagi semua berempat langsung dapat hadiah. Silakan, betul, salah, ataupun kurang tepat dan lain sebagainya, tidak apa-apa, tetap diupayakan gitu loh. Monggo, yang lain barangkali ada yang mau ikut berkompetisi bersama Mas Arif Erlangga. Ada yang mau menyampaikan conclusion untuk acara hari ini? Yang penting berani dulu Bapak Ibu. Monggo silakan. Yang penting berani dulu. Nah, lumayan gitu ya, ikut seminar harga 100.000 dapat cashback 100.000. Nah, monggo minimal ada 2 lah gitu ya, minimal ada 2 lah. Minimal ada 2. Nanti hadiahnya kita bagi 2. Jadi ini 1 orang dapat 2 voucher. Ada lagi?
Saya mau bicara.
Oh siap, Pak Arthur Lapian ini ya.
Ini langsung direkam ini. Ya, saya sudah lama sih tidak ini pernah
Silakan,
ikut pelatihan. Kalau melihat dari materi tadi yang ada, itu hal-hal yang baru yang saya temukan juga, di mana ada diterapkannya metode-metode baru untuk termasuk pengukuran dari segi kedalaman lukanya, kemudian perawatan lukanya dalam bentuk semacam diberikan oksigen, ya, oksigen untuk memberikan keleluasan pada luka untuk menutup, dan terapi dilaksanakan untuk kalau dia diabetes ya tetap terapi diabetes tetap dilaksanakan. Untuk pembicara kedua juga saya perhatikan ada pertanyaan tadi untuk pembiayaan ya. Memang harus diperhatikan juga segi kemampuan pasien dalam artinya kita memberikan edukasi, karena walaupun ini hal yang baru, jelas untuk pembiayaan perawatan luka itu tidak sedikit. Lagi pula apalagi dengan pasien DM itu pasti lama dan harus bolak-balik dan harus dipertimbangkan dari awal dan berikan edukasi sehingga proses perawatan luka itu akan berjalan dengan baik. Jadi itu hal-hal yang harus diperhatikan. Selain ekonomis, kita juga harus memberikan edukasi yang benar sehingga tidak terjadi putus tengah jalan dalam proses perawatan. Saya kira perawatan di Indonesia juga sudah sangat baik. Jika dibandingkan dengan di Singapura tadi, saya lihat kita juga sudah punya teman-teman yang qualified dalam perawatan luka. Sehingga saya pikir sama sebenarnya, tinggal bagaimana referensi-referensi baru itu kita terapkan dalam prosesnya nanti. Itu dari saya saja sebagai conclusion aja. Sederhana tapi saya pikir itu yang harus diingat oleh teman-teman. Terima kasih.
Baik, terima kasih Pak Arthur Lapian. Oke, nanti kita save dulu untuk conclusion dari Pak Arthur ini. Ada lagi Bapak Ibu yang mau menyampaikan conclusionnya untuk acara hari ini, ya gitu ya. Khusus acara hari ini cuma ada 2 materi ya tadi ya. Silakan. Tadi ada dari Prof Kevin dan juga Jasmine Wu. Ada lagi? Dan mendapatkan door prize utama, ini ada buku dari buku tadi ya, buku tadi dari Malaysia, terutama yang ulang tahun, apakah ada di sini yang ulang tahunnya pada tanggal seminar? Ya, pada tanggal seminar, jadi tanggal 4 dan 5, tanggal 4 atau 5. Nah, yang tanggal lahirnya 4 atau 5 Februari, apakah ada? Yang tanggal lahirnya 4 atau 5 Februari, apakah ada?
Ya ada Pak, adanya 4 Juni.
4 Juni, wah ini masih jauh ini ya. Ada lagi yang
saya minta izin bicara Pak.
Oh ya, Bu Sujati. Ya.
Saya non sewu tidak bermaksud kompetisi, cuman cuman nyoba saja untuk menyampaikan apa yang tertangkap tadi. Saya tertariknya tadi ke manajemen 3R itu Pak.
Siap. Silakan Bu Sujati, kita persilakan untuk menyampaikan konklusi.
Ya, terima kasih. Untuk materi 3R tadi saya tertarik untuk materi 3R dalam manajemen chronic wound itu dikatakan bahwa itu wound by time prinsip. Yang tertangkap saya tadi itu adalah pada tahapan intervensi ya. Jadi pada tahapan intervensi kita menggunakan prinsip time dari exudate manajemennya, kemudian manajemen biofilm terutama tadi ya terkait dengan materi juga infeksi, manajemen luka infeksi gitu. Jadi artinya di R1 itu termasuk dalam tindakan assessment, intervensi sampai implementasi. Sedangkan R2 reactive wound healing factor berarti kita mensupport faktor-faktor yang mempercepat penyembuhan luka. Faktor-faktor yang mensupport penyembuhan luka seperti hygiene, kemudian debridement yang baik, dan terutama juga nutrisi gitu ya ke pasiennya. Lalu remove possible potential factor cause wound healing delay, membuang faktor-faktor, menghindari faktor-faktor yang menghambat penyembuhan luka seperti kata Mas Erlangga tadi, menghindari faktor-faktor atau mengkaji, memperhatikan, mengontrol faktor-faktor penghambat seperti apakah dia ada luka, ada penyakit diabetes mellitus, anemia dan sebagainya, penyakit-penyakit kronis yang lain yang menghambat penyembuhan luka. Terutama juga lingkungan klien seperti penggunaan sandal diabetes, penggunaan balutan yang mengamankan luka, seperti itu Mas. Terima kasih, itu saja.
Baik, terima kasih Bu Ketut. Ya, ini tadi sudah menyampaikan dari Bu Ketut tentang conclusion di materi yang barusan tadi ya. Baik, masih ada lagi Kang, ini satu orang lagi ya, biar langsung merata gitu ya. Satu orang lagi barangkali ada. Saya pengen nanti kita, berarti nanti kalau cuma 4 orang nggak ada kompetisi ini ya, langsung semuanya dapat hadiahnya. Ada lagi satu orang? Barangkali yang ini ya, yang ulang tahunnya di awal Februari, apakah ada gitu ya, yang nyerempet dari tanggal seminar? Yang
ini kepengen seminar masuk.
Bu Rahmasari tanggal berapa ulang tahunnya?
Tanggal 5 hari ini.
Hari ini ulang tahun. Baik.
Iya.
Kalau Pak Farhad Anwar, ini ulang tahunnya tanggal berapa Pak? Tadi kayaknya mengacungkan tangan.
Tanggal 6 besok Pak. Tanggal 6 besok.
Baik. Yang paling nyerempet, yang paling pas untuk kita kasih hadiah adalah yang tanggal ulang tahunnya.
Bu Hari.
Bu Rahmasari ya. 5 Februari. Betul ini ya. Nanti coba kita cross check dengan KTP-nya. Gitu nggih? Betul ya? Sudah sesuai ya dengan KTP-nya? Nanti akan kita hubungi, kita cocokkan dengan tanggal di KTP-nya apakah betul. Kalau memang betul nanti akan kita kirim bukunya sesuai di alamat Bu Rahmasari. Untuk yang lain barangkali ada yang masih pengen menyampaikan conclusion-nya, kurang orang saja nih ya, orang saja gitu ya. Satu orang saja barangkali yang pengen menyampaikan konklusinya langsung dapat hadiah gitu ya. Wah, langsung dapat hadiah. Nah.
Halo, assalamualaikum.
Waalaikumsalam.
Waalaikumsalam.
Kebetulan kelahiran saya Pak tanggal 1 bulan 2 Februari.
Oh baik. Ini untuk yang buku tadi kita ini kan ya kita berikan yang ulang tahunnya paling mendekati tanggal seminar, dan ternyata tadi ada Bu Rahmasari ulang tahunnya pas 5 Februari hari ini ya. Hari ini beliau sedang berulang tahun, jadi kita ucapkan selamat buat Bu Rahmasari, kita kasih spesial dari panitia seminar kali ini. Nanti akan kita proses dengan tanggal di KTP-nya. Baik, untuk satu orang lagi barangkali yang mau menyampaikan konklusinya, apakah ada?
Saya Pak.
Mas Hilmi, kemarin sudah Mas Hilmi ya. Nah, yang sudah tidak bisa ini Mas.
Oh, oke.
Yang lain. Yang lain masih adakah? Baik, kalau gitu kita sambil data dulu. Untuk Pak Airlangga Arif, bisa connect kembali ke monitor Pak? Nggih. Pak, kita minta datanya, asal daerah dari mana jenengan?
Jakarta Pak.
Jakarta.
Ya.
Instansinya di mana Mas Arif?
Oh saya kebetulan Fakultas Ilmu Keperawatan UMJ, tapi alumni sih saya.
Oh. Kalau kerjanya sekarang?
Baru lagi perpanjang apa STR.
Nih, ya ada apa? Nomor HP-nya Mas Arif?
0896
0896
2605
2605
2644
2644. Saya ulangi lagi cross check data 0896 2605 2644.
Yang ini kalau Oppo.
Oh maaf Pak, bisa diganti nggak nih saladnya?
Oh gitu ya, silakan.
0831
0831 ya
84 933
933
046
046. Saya ulangi lagi cross check 0831 84 933 046. Betul?
Ya betul Pak.
Baik. Terus yang kedua Pak Arthur Lapian. Masih bisa connect Pak di monitor?
Ya, sebenarnya teman-teman aja lah. Nggak apa-apa, 0812.
0812.
Sorry. Itu untuk pulsa atau apa?
Nanti kalau memang tidak bisa untuk kita ada akun OVO-nya, kita ganti dengan pulsa.
Oh iya, boleh. 0812
0812 berapa? 0812
430 7148.
Baik, saya ulangi lagi cross check datanya. Nomor HP Pak Arthur Lapian 0812 430 7148. Betul?
Iya, betul.
Baik. Ini asal daerah dari mana Pak?
Rumah Sakit Umum Daerah ODSK Provinsi Sulawesi Utara.
Baik, sudah kita simpan di RSUD Sulawesi Utara. Baik, selanjutnya tadi ada Bu Ketut Sujati, bisa connect kembali Bu Ketut mikrofonnya.
Dalam Pak.
Baik Bu Ketut, bisa disebutkan asal daerahnya dari mana Bu Ketut?
Saya orang Bali tapi di Sumatera Pak.
Oh, aslinya dari Bali tapi di Sumatera. Instansinya di mana Bu Ketut?
Iya. Dalam?
Instansi kerja.
Dalam Pak? Oh, di Poltekkes Palembang. Poltekkes Palembang, Prodi Keperawatan Batu Raja.
Bisa disebutkan nomor HP-nya?
0812
Iya.
7386
Iya.
9128.
Baik, saya ulangi lagi Bu Ketut nggih. 0812 7386 9128, betul?
Nggih.
Baik, terima kasih Bu Ketut. Untuk selanjutnya Bu Rahmasari tadi yang hari ini ulang tahun. Bisa connect lagi Bu Rahmasari. Bu Rahmasari, apakah bisa connect? Atau mungkin sambil menunggu Bu Rahmasari, ada satu orang lagi yang mau untuk menyampaikan konklusinya, langsung dapat hadiah tanpa diundi loh ini ya. Wah, ini karena tidak ada yang mau ini, masih ada satu voucher lagi. Apakah ada? Mas Januar Nursid, apakah mau menyampaikan konklusinya? Ini sudah buka mikrofon.
Ya dari Siti.
Baik. Kita baik, untuk Bu Rahmasari bisa connect kembali Bu Rahmasari. Ya. Betul 5 Februari ya tanggal lahirnya, betul seperti itu nggih? Baik. Baik, nanti akan kita cross check di WA untuk data di KTP-nya. Baik. Bisa disebutkan nomor HP-nya?
0821
0821
9833
9833
6508.
508. Ya, saya ulangi lagi ya. 0821 9833 6508. Betul nih? Betul ya?
Iya, betul.
Baik. Baik, apakah ada satu orang lagi yang mau menyampaikan konklusinya? Ini ya, masih ada satu voucher tanpa diundi ini kita. Sayang sekali ya. Silakan buat teman-teman semuanya tanpa diundi nyampaikan konklusi dapat saldo OVO 100.000 gitu ya. Kalau tidak punya OVO nanti kita tukar dengan pulsa. Ada lagi? Satu orang saja nih ya.
Halo Pak.
Ya, ini Wismawati Kristina.
Ya, saya mencoba untuk
baik. Baik, silakan bisa dibuka kameranya. Sebutkan nama dan asal instansinya dulu nggih.
Nama saya Wismawati Kristina. Saat ini saya sedang tidak bekerja, Pak.
Baik, silakan.
Saya tertarik dengan itu. Risiko pada kulit, kekerasan pada kulit itu ya ada 3 itu, purpura fikun, bekas luka, sama atrofi kulit. Di mana kekerasan pada kulit itu dapat dilihat dari kelemahan kulit yang dibuktikan dengan ketidakteraturan struktur atrofi dan kehilangan kekuatan karena hidrasi kulit yang abnormal, dan juga perfusi yang buruk, gangguan desquamasi, hilangnya kolagen atau elastin, peradangan dan jaringan parut yang berlebihan. Itu saja Pak dari saya, terima kasih.
Baik, terima kasih untuk Mbak Kristina gitu ya. Asalnya dari mana Mbak Kristina? Alamat?
Ya. Saya tinggalnya di Jakarta, Pak.
Oh, di Jakarta.
Iya, di Jakarta.
Langsung saja kalau gitu, terima kasih Mbak Wismawati. Bisa disebutkan nomor HP-nya? Nanti akan kita kirim saldo OVO-nya.
0812
0812
1639
1853
1853. Iya.
Saya coba cross check data lagi. Nomor HP-nya 0812 1639 1853, betul?
Iya, 0812 1639 1853. Ya, Pak.
Baik, kalau gitu Bapak Ibu sekalian, terima kasih sekali atas partisipasinya di seminar internasional kali ini. semoga Bapak Ibu enggak kapok ikut seminar-seminar kita gitu ya, karena ke depan kita akan juga tetap ada seminar kayak seperti ini gitu ya. Dan pastinya kita akan memberikan SKP yang lebih besar lagi harapannya seperti itu. Jadi nanti Bapak Ibu sekalian semoga tetap berantusias untuk ikut seminar di Go ICARE ini, dan ke depan semoga harapannya SKP juga akan kita tambah lagi. Harga kita usahakan tetap seperti itu nggih. Nah, ini mungkin harapannya Bapak Ibu sekalian. Harga tetap, SKP tambah. Baik, demikianlah untuk sesi webinar internasional kali ini. Semoga apa yang didapatkan ya bisa bermanfaat gitu nggih. Tidak hanya untuk hari ini saja, tapi untuk bekerja di seterusnya dan seterusnya seperti itu. Demikian dari kami, mohon maaf bila ada salah kata dari panitia maupun segenap tim yang bertugas. Mohon maaf ada salah katanya. Sekian dari kami. Kita akhiri. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam.